यस विवेक. हाय.
Hi, sir.
हाय प्रतीक.
Hi, all of you, sir.
बस हमारे साइड से विवेक बंदे करके हैं, आर थर्ड ईयर रेसिडेंट,
अच्छा.
तो विल प्रेजेंट द केस.
Okay, he's presenting the first case or
हाँ
all the
फर्स्ट
cases.
केस, यदि टाइम रहा तो सेकंड भी कर देगा.
हाँ, अच्छा.
विवेक को कुछ दिखाया नहीं केस, इसलिए
हाँ,
पहले दूसरा आदमी था, फिर लास्ट मोमेंट में विवेक को बोला.
अच्छा. Okay. नंदलाल का क्या हुआ?
नंदलाल कहीं बाहर गए.
Okay, चलेगा.
विवेक इज सर्जिकल
So,
ऑन्कोलॉजिस्ट.
okay.
हाँ.
So I think we have time for 2 cases at least, I think.
हाँ जैसे भी टाइम रहे. एक डिस्टल फीमर है, एक
हाँ,
स्कैपुला वाला है, और एक
हाँ,
बिनाइन केस है, तो 3 केस है टोटल.
चलेगा ना. So is he okay presenting all the 3?
हाँ कर देगा विवेक, कर देगा सब कुछ. विवेक थर्ड ईयर है,
विवेक
अभी तो
का हो.
एग्जाम देना है उसको. पास नहीं होना विवेक. विवेक मुंबई या पुणे
हाँ.
आने वाला है भाई.
Oh, okay, okay, great. So I think Yogesh Panchal sir will join us,
हाँ
and he will be introducing the session,
बिल्कुल
and then you can introduce and say what is the plan,
बिल्कुल
and by that time hopefully other panelists will join in.
बिल्कुल.
I'm not sure Janit sir is joining us because I think
जनित शायद कहीं बाहर है. मेरा मैसेज किया उसको, उसके बाद मैंने उसको भी मैसेज किया, ऋषि को. वो भी कहीं
हाँ,
बाहर है. वो ट्राई करेगा, ऋषि करेगा ज्वाइन, ट्राई करेगा वो भी.
okay, हाँ, हाँ. So
जनित कहीं
Himanshu,
सिंगापुर में, नेपाल में नहीं है वो.
yes, yeah. Himanshu, Srinath and Amrut will be joining us.
हाँ तो बस बढ़िया.
हाँ, ये लोग हैं. Let's see अभी कौन कौन आता है.
बिल्कुल बिल्कुल.
Okay. चलो विवेक, बेस्ट ऑफ लक. आराम से करना. टाइम का कोई हैसल नहीं है. You can take your
जैसे
time and
अपन
present.
केस करते हैं, देखते हैं, वैसे टाइप से बोलना है. उसमें कुछ एक्स्ट्रा बोलने की जरूरत नहीं है.
हाँ, हाँ,
शॉर्ट केस ही है. ऐसे भी एग्जाम में सर्जिकल ऑन्कोलॉजी शॉर्ट केस ही आता है.
exactly. हाँ,
ऑर्थो में भी शॉर्ट केस ही है, फाइनल एग्जाम में आए तो
क्या
दोनों
यार.
जगह शॉर्ट केस.
So we'll wait till 5:30
हाँ
and
बिल्कुल.
then
उसके ज्वाइन करते हैं. यस.
okay, okay,
यस.
चलेगा.
हाँ.
Good evening, Panchwat sir.
Good evening, Pratik. Good
Hi,
evening.
hi, sir. First of all, congratulations on the Ironman.
Oh, thank you very much. Thanks.
And thanks for joining today. We'll just wait for 5 minutes for more people to join in.
No issues. No issues.
And then we can start. The recording has started already.
Yeah,
we'll
no
just
issues.
wait for a few more minutes and then
No problems. No worries.
Hi everybody. Hi Yogesh sir. Hi Abhijit sir. Hi Pratik.
Good evening.
hi Srinath. Thank you for joining in. So we'll just wait for 5 minutes before starting the proceedings.
Hi Amrit.
Good evening to all who are joining us in. This is the last session of this Sarcoma Education Foundation initiative. We are just waiting for a few more minutes or more people to join in, and then we'll be starting at 5:35 p.m. Today's session is chaired by Dr. Yogesh Panchwat sir, and Dr. Abhijit Salunke is the moderator. So it's 5:32 now. We'll just wait for a few more minutes and then start.
Abhijit, how many cases are we discussing today?
Good evening sir.
Hi, good evening. How
Good evening,
many
sir.
cases? How
So
many
2 या
cases?
3 try करेंगे sir. 2 या 3 cases try करेंगे sir.
Okay, all right.
So one is distal femur, second is shoulder or scapula, and third is forearm. So
Okay.
2 malignant, 1 benign case.
Okay, all right.
So 2 are MCH residents are there, sir.
Okay.
One is third year and one is second year.
Okay.
So they will present, sir.
All right.
Yes.
Sir, I think we can start 5:35. To start and then let people join in. So you're muted.
Okay, am I audible now?
Yes, sir.
Yeah, great. Good evening to everyone, and it's a great pleasure to have you all with us. And thanks to this initiative by Sarcoma Education Foundation. We have had some fantastic topics covered beforehand under the banner of or under the program of Nurture the Future. And the idea was to sort of inculcate or renew the interest in orthopedic oncology amongst our peers and junior colleagues, so that we can have more and more people taking up this particular specialty or learn to manage these particular cases in the correct way. And today is going to be the concluding session in which we are going to have a case-based discussion, and we will be discussing a few cases. It will be moderated by Dr. Abhijit Salunke from GCRI Ahmedabad. And we have a few experts with us who will be acting as a panelists, and hopefully you will be enjoying this particular discussion. And this is one particular session in which we will sort of apply all the knowledge that we have gained over the last few months as to how to sort of actually treat a particular case, how to work it up, and how to manage it, or how to surgically treat it in your OPD once such a patient would come to you. So over to you, Abhijit. The stage is all yours.
Sir, you're muted.
So my screen is visible.
Yes. You got to make it full screen.
Yeah, this is okay.
Yes, sir. Yes, sir.
Yes.
Please go.
So we will have a few cases and we will go by the case-based approach. So we have two colleagues from GCRI. One is Dr. Vivek Bande and second is Dr. Anish Chaudhary. Both are MCH surgical oncology residents, third year and second year. So they will present the case and they can answer together also. Then in moderators, we have who can ask the questions. So we have Dr. Pratik, Yogesh Panchwat, Dr. Srinath, Himanshu, Rohila from Delhi. So greetings from GCRI. So we just directly start with the case presentation. So it's a short video. All clinical findings will be shown, and then the resident will present his findings and we can ask the questions to them. Is this format okay, sir?
Yeah, that is fine. Everyone else can also chip in with their ideas.
Yes.
And the way they would probably manage this particular case.
Yes, definitely, sir. It's a two standard cases, sir, what we are presenting.
All right.
Okay, sir. So this is a clinical scenario, and it's a 13 years boy with pain in right knee for 3 months, swelling for 2 months duration, difficulty in walking for 2 months duration. There is no history of trauma, no other significant history. And in orthopedics exam or in surgical oncology exam, orthopedics case is a short case. So these are the findings what they are given, and they need to examine the patient and summarize the case. So these are the clinical findings. It's a 13 years boy with swelling, pain, and difficulty in walking for short duration of around 2 months duration. This was his clinical picture. This is how the patient can be seen from the sides, from front. And this is a small video. So we are examining the patient in all these positions. Yeah, so Dr. Anish, can you hear us?
Hello.
Yeah, Anish.
Can you hear me? Hello.
Yeah, Anish, you are audible.
Yes, it's audible.
Yeah. So you got the history of
Yes,
this
sir.
patient. It's a 13 years boy with pain, swelling, and difficulty in walking for around 2 to 3 months duration. And this is the clinical picture, and you have seen the patient in your OPD. So these are the
Yes, sir.
findings. So how will you proceed with this case, and what next steps you want to do for this patient?
First, I would like to examine this patient.
Yes.
So on clinical examination, on inspection, we see a swelling lower the thigh, which is involving the aspect of the joint, complete disfigurement location. It's the swelling ends, and on lateral aspect, it's lateral of the skin looked the skin looks straight over the swelling. So next on palpation, the swelling, we have to look for tenderness as well as rise in local temperature over the swelling.
So you require next
I'm
inspection.
audible
So you need to confirm your inspectory findings, what you have seen. Yogesh sir, any questions for
on
Anish?
palpation. Yes.
No, let him finish, and
Okay,
then
sir. So
maybe we
I'll
can.
show whole clinical examination findings, sir.
Yeah, that will be a better idea in
Yes,
the
sir.
interest of time.
Yes, I'll show it, sir. Yes, sir. These were the findings, sir. So we can proceed with the questions to him, Anish, sir. Yogesh, sir.
Yeah, Anish, what do you think this is? What could be this case of? Anish, can you hear us?
Hello, can you hear me?
Yes, Anish.
Hello. Yes. This looks like to be a soft tissue sarcoma arising from the distal part of the thigh. We have to. I would like to proceed with the next step to see its origin, whether it's originating from the bone or from the soft tissue, to rule out any bony tumor.
So
On
the
clinical
patient's age is 13 years, and
Yes,
it's
sir.
a pretty short history. I think it was 3 months history,
Yes, sir.
and a fairly rapidly growing size of the lesion. Why do you think it is a soft tissue
Yes, sir.
sarcoma? And, what is the common age for a soft tissue sarcoma? Age group of presentation?
It's later in 50s to more than 40 to 50 years. In
Right.
this case, I would suspect more to be a bony tumor, more so to be osteosarcoma or ring sarcoma or something like that. That is from
Yeah,
the
so
bone.
you said it was a soft tissue sarcoma. That is why I posed that question. Okay. Why do you think it's a tumor?
Because it's rapidly growing in size and it's there's the palpation findings I would see, and given this age of this patient and the skin over it, it's stretched with dilated, it's visible dilated veins are there. Most probably a neoplastic process is there rather than
Okay.
any inflammatory or something there.
Inflammatory, why not infective?
No history of fever in this patient.
Right.
Any rising surface temperature or some stigmata of inflammation.
Okay. Okay. All right. So what would you like to do for this particular patient?
After examination, I would like to order an X-ray to see the probable position of the tumor with respect to the bone.
Okay.
And after that X-ray, I would like to do the local part imaging, preferably an MRI. And
So let's wait for a while here. Let's wait for a while. You said that you wanted an X-ray of that particular affected part, right? Yeah.
Yes.
Yeah. Okay. So Abhijit, do we have an X-ray?
Yes, sir. We have the X-ray, sir. Sir, any other questions from other
Yeah.
analysts like Srinath or Himanshu or Pratik?
Sir, I have a question for Dr. Anish. Dr. Anish, on clinical examination, how do we differentiate soft tissue swelling from a bony swelling? Because your first DT was soft tissue. Now, on clinical examination, how do we differentiate the both?
By first consistency of the swelling, whether the swelling is fixed to the bone or whether it's minimized from with respect to the bone, as well as the position with respect to it. In this case, the whole of the lower femur appears to be enlarged. Hello. Hello.
Yeah, your voice is not very clear.
Yes, sorry. Consistency of the swelling as well as ability of the swelling with respect to the bone. This gives a clue about the whether it's rising soft tissue sarcoma per se or a bone tumor.
So is there any test that you do to determine that, Anish? Your voice is echoing actually.
Yes, sir. Actually, there's I can't find a place with this connection. Let me go to a bit.
Vivek is there, Vivek?
Hello. Yes, sir.
Vivek. So you can answer until Anish gets correction of his internet. You can answer
Fine.
the questions.
So, to differentiate between the bony and soft tissue swelling, one is soft tissue swelling will be mobile along perpendicular to the long axis of the bone, while bony swelling will be fixed irrespective of the means. It will be fixed in the perpendicular as well as the axial. Yes, sir. It will be bony hard in consistency.
And one more thing is it will be in continuity with the bone, the swelling. You can't differentiate the borders away from the bone. So that is
Yes.
one other thing that you can differentiate between soft tissue and bone swellings.
Yes.
Yes, so sir, we show the X-ray to both Anish and Vivek, sir.
No, just a minute. I wanted to actually ask Anish, since he said it was an osteosarcoma. I was wondering why would he be saying that? Why could it not be a benign aggressive tumor? Or maybe Vivek can take it if Anish is still having issues with his internet.
Can you hear me? Is I'm there here?
This question is applicable before having a look at the X-ray.
Okay, sir.
Why not a benign aggressive neoplasm? And why did you say that this was an osteosarcoma? Because osteosarcoma is something maybe a pathological diagnosis or at the most a radiological diagnosis in a very classical case scenario. And if you directly say an osteosarcoma, I would like to know why are you saying osteosarcoma? Why not a benign aggressive neoplasm?
It can be a benign aggressive disease, but given that short duration of the history and that it's a bony swelling with overlying dilated veins, etc., is present.
Yeah.
So most probably I would go for I would like to rule out the malignant etiology first rather than considering a benign diagnosis and then.
Yeah. So what I would suggest is that do not give an pathological or a radiological diagnosis before you have seen the X-rays.
Okay.
Or have gone through the other imaging information that will be shared with you. you need to give a differential diagnosis considering the patient's age and the site of or the location that is involved. So that's one suggestion. Don't jump to a pathological or a radiological diagnosis. It'll just tell the examiner that probably you know the case or you have seen the x-rays beforehand.
Yes, sir.
Yes, sir.
Okay, we can go to
Yes,
the
sir.
x-ray.
Yes, sir. So this was the X-ray. So first Anish can describe, and anything remaining then Vivek can describe it.
So in the X-ray, we see the like so we see a lesion arising from the distal part of the femur, and the cortex. This is a lesion with a periosteal reaction, I think, is visible. And we see that periosteum has been raised in the elevated in the upper part. The lesion is arising most from the metaphysis region and extending into the diaphysis of the bone.
Okay, what else do you want to tell us? What else does the x-ray tell you?
It gives us a hello.
Yes, Vivek, you can add your answer, Vivek. Anything
Sir,
extra? You are seeing more than what Anish is seeing.
So this is an X-ray AP view and a lateral view of a knee joint involving the distal part of the femur and proximal tibia fibula, which is of an immature as epiphysis is seen, and there is a periosteal reaction seen in the distal part of the femur, as well as soft tissue component is also soft tissue involvement is also seen on this X-ray, sir.
Okay, what else? Would you like to give us some more information? Would you like to comment upon what's the matrix, what sort of a lesion it is, what is the zone of transition, what is the status
Yes,
of
sir.
involvement of the epiphysis, what
So,
is the status of
yes, sir.
involvement of the joint? Yeah, because I mean, strictly from an examination perspective, it's better that only you talk and the examiner talks to the minimum. That's gives you the best chance of passing. But here, I think the intention is not just to have a case discussion from an exam point of view, but also have a discussion regarding the clinical aspects and the management aspects. So we will probably need you to comment on that, and then we will move on.
So comment
Yes,
on
sir.
the zone of transition. What is the content of the tumor?
So this is there is a wide zone of transition with a osteoid
Osteoid matrix.
matrix, and Codman's triangle is seen, sir. And
Sir commented on the involvement of the physis.
epiphysis doesn't appear to be involved in this case, sir. And
Sir also had asked about the joint involvement. Do you think your joint is involved?
no, sir.
You would also like to probably make a comment upon which side the soft tissue component is, because your management decisions or your further interventions probably will depend on that.
So
Lateral side, sir. Soft tissue extension is more on the lateral side, sir.
Right.
So anything extra from all examiners need to be explained in the X-ray?
Yeah, Abhijit, I have a question.
Yes, sir.
Yeah, it's Janif. One question I have for the candidate is
Yes.
this X-ray enough for you? Ideally, what sort of an X-ray would you like to get in a?
Is this a good X-ray, Vivek? What Dr. Janith wants to ask?
No, sir. Sir, actually, ideally, X-ray should be involving the entire bone with the proximal and the distal joint.
Okay, so this is not a good X-ray. So you need to tell the examiner that it will be really great that you can provide us an X-ray which will be of a full length. So that can be commented.
Yes.
Okay, sir, anything extra on X-ray, sir?
Yeah, I would like him to sort of comment on the nature of the lesion, zone of transition that he did mention later on,
Yes, sir.
and the ossification, the ossified matrix that is seen in the soft tissue component, as well as the intramedullary area of the lesion.
Yes, sir. So, sir, this is a simple method what Vivek, we are teaching you in our all OPDs, that you are told about age, you are told bone, which part of the bone you are told, metaphysis. Then sclerotic you are told, osteoblastic matrix you have described, it's ill-defined, wild zone of transition, periosteal reaction and soft tissue mass. But in exam, you can't say all these things, A, B, C, D, E, F, Z. So you need to summarize it. So this is a
Yes.
simple way how you can summarize it for the examiner. So he can ask more questions to you. They can ask to draw you the periosteal reaction. What is Codman's triangle? They can ask. They can ask what is sunburst pattern, and other things. The examiner may ask you to draw on a pen and paper. That what is meaning of Codman's triangle and why it occurs. So that is commonly asked in all the exams. So you can summarize in this simple line that radiograph of skeletal immature individual, which is sclerotic with wide zone of transition, with periosteal reaction, with soft tissue mass, and lesion looks to be malignant to you. Again, what Yogesh sir said, you can't comment exactly on the histopath type. So you can say it's malignant bone tumor. Again, the examiner insists what you want to give some exact diagnosis, then you can say osteosarcoma, or if you are not sure, you can say, I would like to give differential diagnosis, 1, 2, and 3. So this is okay with the candidate, sir, Yogesh sir, to say differential or?
Yeah, I would say if it's a short case for them, I
Yes,
would
it's
say
a short case, sir. Both
yeah.
MCH and orthopedic DNB or MS ortho, sir, it's always a short
Yeah,
case.
correct. So I would say that this is most likely a primary neoplastic lesion affecting the distal end of the femur, right, left, whichever side. Most likely an malignant neoplasm. But I would also like to keep a differential of an rapidly growing benign aggressive neoplasm in the 13 years old boy with a functional deficit of so and so, so and so, so and so, and positive examination findings if the examiner insists on asking about the positive clinical findings.
Yes. So you can summarize your positive clinical findings, Vivek,
Yes.
for everyone. So you have seen the case. So just summarize in a line that what findings were there and the history, about the history. So how you describe in the exam, it's a 13 years boy, and then you can describe that way.
Yes, this is a 13-year-old boy who presented with a pain and swelling in the around the knee joint for the past 2 to 3 months, which was rapidly growing, and we had a restricted range of movement on the knee joint, and with a X-ray. So should I describe X-ray also?
No, clinical examination. What sir was saying, for a short case, you need to tell the summary of your case. So 13 years boy with pain and swelling of short duration. Clinically, it was tender with local warmth of temperature, restricted range of movement with normal distal neurovascular function. Yeah, Dr. Janit, anything extra you want from Vivek about this case of clinical examination and X-ray?
I think for short case that should be enough. But then once you go to X-ray, I think there'll be more questions.
Okay. So X-ray we have seen. So yes, Yogesh sir, next question, sir.
So my next question is going to be, okay, you have seen the X-ray. Suppose that you have got a full length X-ray, the proximal femur does not show any obvious lesion or escape lesion. What would you like to do next?
So next step will be, sir, lab investigations, including the complete hemogram and renal function test, liver function test, including the alkaline phosphatase, LDH, and uh, serum electrolytes, calcium, and serum calcium, and sir, followed by the local imaging, that is MRI of the affected joint, affected limb, as well as followed by to know MRI for the followed by biopsy, sir.
No. MRI of the affected limb, you said. You mean to say the entire limb?
You need to write
No,
a
sir,
prescription,
not
Vivek,
entire limb, sir.
for the
Affected,
radiologist.
sir.
So what you will say for them?
So MRI of the knee joint, sir.
Only the knee? Will that be enough? They will do only the knee. They won't cover the femur there.
Sir, I mean MRI femur, sir.
But
Right.
Dr. Vivek, hi,
Alright.
Dr. Manshu, can I ask one question?
Yes, sir.
Dr. Vivek, why Dr. Yogesh is specifically asking you is, why do you want to do the MRI of the whole femur? First thing. And why do you want to do an MRI? Why not CT scan of the femur? You said it is a bony neoplasm. Why MRI is more important than doing a CT scan of femur?
Sir, MRI is a good modality to assess the soft tissue extension, to know the neurovascular status, to know the marrow involvement, to know the and to for knowing the skip lesions. The entire MRI femur is important, sir.
Yeah. So that is what sir was planning to ask you. When you write a MRI, you can say MRI of the distal femur with the screening of the whole femur, and you can also mention tumor protocol. When you write tumor protocol, the radiologist at a center who is examining this or who's screening it, he would eventually screen the whole femur if you write tumor protocol. And do you want to use contrast or non-contrast MR?
Contrast, sir.
Okay. Why not a non-contrast MR?
So contrast MR will give us a status about this. On contrast imaging, there will be a a tumor will be enhanced on T2, sir, and sir, also to assess the vascular status. Also, contrast will be helpful, sir.
No, it's generally to differentiate between marrow edema and the tumor extent within the tumor, you give contrast. Also to differentiate whether it is an inflammatory or an infective swelling compared to a neoplastic swelling with an extraosseous component. If there is a neoplastic swelling, it would be a homogeneous enhancement. If it's an infective etiology, it would be a peripheral ring enhancement. And why not CT? Or when do you advise a CT scan in a neoplastic lesion?
So CT scan is has a low sensitivity for this assessing soft tissue extension, as well as to assess the marrow extension, sir. And CT scan is good for the cortex, sir. And
yeah, so if there is a lesion not pertaining to this case, if there is a lesion which is a skeletally grown mature child, and you want to see whether there is a juxta-articular fracture and there would be a contamination of the joint, so you can see cortical breaks in the joint in the CT better rather than an MR.
yes, sir.
Yes, Yogesh sir. Any questions about MRI, sir?
No, this should be fine. I think we'll have to move on.
We'll show those MRI images, sir.
Yeah.
These are the MRI images. So one thing we missed, it should have a scale. So contrast, full length MRI and a scale. So what is significance of scale, Vivek? Why scale is important here?
Sir, scale will it is for the giving us a measurement, sir, for the assessing the length, sir.
Okay, so you can plan your surgeries based on this.
Yes, yes, sir.
So can you describe the MRI for what Yogesh sir has asked? So whether the physis is involved or not, and joint is involved or not, and sir had asked where is the soft tissue swelling more? So medially or laterally, you can just answer on these MRI images. So this was T1, this was T2, and these were the other images. So these were the 4 images what were available. So Srinath, any questions
sir,
on MRI to Vivek? Pratik,
Yeah, one question to Dr. Vivek. Like, sir showed one T1 weighted coronal and one T2 weighted coronal. So is there a preference in that if you want to see? And as sir asked, you can also describe what are the findings you're basically looking at when you're looking at an MRI.
Yes, sir. Sir, I would like to see the T1. Sorry, sir. T2 image, T2 MR image. For as it will help us differentiate between the no, sir. Sorry, sir. I would like to see the image on T1 as it will help us differentiate between the marrow edema and the pathology, sir.
Yeah, okay. So Vivek, relax. Okay, this is Aram, sir. This is not an exam. It's just a discussion that is happening. So you can present easily. So that is one. T1 weighted is preferred over T2 weighted, as you mentioned. So what are the findings that you're looking at when you're looking at an MRI?
So this is a full-length MRI of a femur of a skeletally immature individual with a marrow involvement. Extending up to the distal part of the distal part of the femur, that is it is going up to the epiphysis but not involving the epiphysis, and with a lateral soft tissue extension.
Okay. And the other reason that you see is whether there's any skip met or any other.
Sir, there doesn't any skip lesions in this MRIs.
Okay. Is the joint involved or not involved?
So joint is not involved.
Yeah. So here we are looking at 2 joints, hip and knee. So obviously the lesion is closer to the knee joint. That is what we are looking at, or maybe wanting you to comment on. And how is that significant or relevant if the joint is involved or not?
So for the surgical planning, it is important, sir. As if the joint is involved, then osteoarticular resection will be there, and if the joint is not involved, then intercalary resection. We can get away with intercalary resection, sir.
Yes, Yogesh sir, any next question, sir? After MRI, sir?
No, let him go on. Let him
Yes,
tell us how he's going to proceed further.
Yes, sir.
So maybe the other scans or the other cuts.
So these were the other cuts, sir. This was T1, this was T2, sir. And
So
I have
the
a
axial cut.
yes, sir.
Dr. Vivek.
Yes.
Dr. Amrit here from KMC Manipal.
Yes.
Why is it important which side the soft tissue extension is more? How will it affect your further management?
Sir, I'll plan my biopsy accordingly, and I'll plan my future incision accordingly. So my future incision in this my biopsy will be on more through the lateral side, as it will cause a less tissue contamination, normal tissue contamination, and followed by a future surgical plan. Incision will be along that side only, sir.
So you're saying it will be along the line of your future surgical plan, right? So what is the surgical plan in this case?
I think we should bus ask him what next step
Sir, first.
Fair enough.
Before going to the surgical plan.
Yes, sir. So this was his next step, sir.
Yeah.
Abhijit,
So it
sir,
is important question, sir.
before that, that axial scan, if you can just show.
Yes, sir.
And,
This was
and what what is it that will look, and why is this important?
So Dr.
So
Vivek,
yes, sir, yes. I'll see the affected compartment muscles as well as the neurovascular. Yes. So in this case, a neurovascular bundle is appears free, sir.
Okay.
Close but free.
Okay, what next would you want to do, Dr. Vivek?
Followed by MRI femur, I'd like to proceed with a bone biopsy.
So what kind of bone biopsy you want to do? You want to do an FNAC, you want to do a core needle biopsy, you want to do an incisional biopsy?
So core needle biopsy with a Jamshidi needle, sir.
Why not incisional biopsy?
Sir, with a core needle biopsy, I'd like to I'll get the same amount of tissue with as with the incisional biopsy with a minimum contamination and with a minimal in bone core needle biopsy. I'll take only a small stab incision, while in incisional biopsy, we'll take a big incision of 2 to 3 centimeter, and then followed by extensive dissection, and which might result in a hematoma and a contamination of a normal tissue plane, sir.
Okay. How many cores would you want to take, or do you want to go within the bone, or an extra osseous component is fine enough for you to take the sample?
Number of cores.
Sir, I'd like to go.
You take.
Number of cores will be, sir, at 3 to 4, with the sir. I'd like to go within the bone also, sir.
Why do you want to go
not pierce the opposite cortex?
Why not just the extra osseous component? Because if you're going within the bone, you are causing a trauma to the cortex if it is not in the direction of the cortical break. You might incite a incidental pathological fracture or a iatrogenic pathological fracture, because extra osseous component is representative enough of the same pathology which is within the bone.
Hey, Dr. Amrit, what you had asked him, the line of incision. So you can repeat a question for him, sir.
How do you decide for which part of the swelling will you take the biopsy, and whether your biopsy cores are good enough or not?
Sir, biopsy cores will be if there's cylindrical biopsy cores or cylindrical 3 to 4 biopsy cores are adequate enough, sir. And
what sir want to ask, which area will target? Center of the bone, periphery of the bone, and which is thought to be a good area which is having a good amount of tumor cells. Any necrotic areas, any viable areas, which is the area what you feel which will be better to target? Periphery or the center of the tumor?
sir, sir, periphery of the tumor, where there is a minimum amount of necrosis, that will be targeted area. And in this case, as there is a lateral extension more, so I'll go through the lateral approach on this.
Yogesh, any question about biopsy, sir?
No, just one quick comment. This is where the MRI is going to help you with contrast, because the contrast is going to tell you which area is viable and which area is necrotic, and you would like to avoid the necrotic part while doing the gun biopsy or needle biopsy. So that's another use of getting an MRI done with contrast, so as to know which viable tissue you are going to target at the time of biopsy. Okay, so in this case, Vivek, you said that you're going to target it from the lateral side, right?
Yes.
Okay, and you'll be doing a needle biopsy, right?
Yes, sir.
Okay, so the biopsy report has come out to be an osteosarcoma. What would you like to do next?
So, as a biopsy shows osteosarcoma, so I'd like to proceed with the metastatic workup, which includes CT scan, contrast enhanced CT scan of the thorax and bone scan. Or if the facilities are available, we can get away with a single modality PET scan, sir.
Why a contrast enhanced CT and not a plain CT?
So non-contrast CT is also, sir, will also show us the yes, sir, metastasis. Non-contrast CT scan will also do, sir.
No, you need to tell what you are doing and what is justified. So in exam, you should be firm about your answer. You can say whatever thing, what you want, but you need to give justification that at your center, CT scan is available, PET scan is available, or the things you need to justify what you're saying. So here, Dr. Ivanshu is asking contrast or non-contrast. So what is significance of that as a oncosurgeon, you think? Contrast and non-contrast CT scan? Which will show metastasis more better? Contrast or non-contrast CT scan?
So contrast CT scan will show metastasis better, but as if it is osteosarcoma and there is a more likely osteodeposition also occurs in the metastatic lesions also. So it will be appreciated on non-contrast also, sir.
So you need to order something to the radiologist. Contrast or non-contrast, what will you write for it? So this is for exam purpose. You are practicing oncosurgeon in next few months. So you need to write something on the paper also to the radiologist. So what will you write for this patient? Contrast or non-contrast CT scan?
So contrast CT scan, sir, for the better delineation of metastasis.
Yes, Dr. Srinath, any question for him about the metastatic workup you want to ask?
Can we do a FDG PET CT scan?
Yes, sir. Instead of going for CT scan and bone scan, we can do PET scan, sir.
So do you want to do a bone marrow? Do you want to do a bone marrow aspiration biopsy for this case?
No, sir. Unlike Ewing sarcoma, where bone marrow chances of bone marrow involvement are high, in osteosarcoma, bone marrow involvement is rare, sir. So I would not like to go with the bone marrow biopsy.
Yeah, Dr. Jennings, any question about metastatic workup from your side?
I think HRCT is usually enough. And when you talk about PET scan, you have to justify using PET, especially if it is a case of osteosarcoma. In the other type of sarcoma, like Ewing's, PET is sometimes justified because then you can get away of not doing a bone marrow biopsy if it is positive. But then in case of osteosarcoma, I think at this level, we should just stick to HRCT and HRCT chest. But again, like Abhijit said, if it's the protocol of your place, then that's your call.
Yes, Yogesh sir, any question about the workup done up till now?
Yeah, so Vivek, can you tell us why are you doing the distant staging investigation? Why do you want to know whether the patient has any other lesion or not?
So it will affect distant metastatic workup will change the stage of the disease, change the prognosis, and thus the management, sir.
Okay, all right. Staging, I agree. Prognosis, I agree. How will it change the management?
Sir, management, whether it if there is a high tumor burden, grossly metastatic disease, so then the intent becomes palliative and not curative, sir. But if there is a limited number of metastasis and then still the intent can be curative, sir.
Okay, all right. So when are you going to say that it's going to be a palliative care, and when are you going to say that the intent is curative?
So gross bony metastasis, multiple site bony metastasis, multiple bilateral lung metastasis, and that if there is a limited number of lung metastasis, then also we can go ahead with the curative, keep our intent curative, sir. But if there are multiple site metastasis, multiple site number of and multiple site metastasis.
I think, one easy way to put it is, if all the lesions are resectable, then probably your intent can be curative.
Yes, sir.
If any lesion is not resectable, then that patient becomes palliative.
Yes.
So Vivek, this was the bone scan. So can you just describe what it is and how it is done? Do you know how bone scan is done? Are you knowing the steps of bone scan? Very important question asked in exam. How bone scan is done, what dye is used, or what things are used?
So in bone cancer, technetium 19 MDP dye is used, sir. Methylene diphosphonate. And
are there any phases of bone scan?
Yes, sir. There are 4 phases of bone scan.
So how this looks to you? Is it metastatic or it's so the humerus is also glowing, femoral head is glowing, bladder is glowing, tibia is glowing. So what do you think? It's metastatic disease or it's normal?
Sir, it is a non-metastatic disease, sir. As so there bone scan usually shows the activity. Bone scan shows the activity, osteoblastic activity more, sir. So there will be the this is a immature skeleton, so epiphyseal activity is seen in the proximal humerus and the distal part of femur. And so the dye is excreted through the bladder. It is accumulated in the bladder. So we are seeing the dye in the bladder also, sir.
Okay. So this is a CT scan. So just showing a single film. So any mets you can see here or no?
No, sir.
This looks okay to you. So this is the Yogesh sir. Next question, sir. We are done imaging. We have got the biopsy report, and
Okay, so how would you want to go ahead now, Greg? You have a non-metastatic osteosarcoma in a 13-year-old boy. You know the extent on the MRI, pretty large tumor. How would you like to manage him?
So as this appears to be a conventional osteosarcoma that is with intramedullary involvement. So I'd like to proceed with, I'd like to know the grade of the osteosarcoma on the biopsy report, and then I'll proceed with the, if it is, then I'll like.
You only said it's a conventional osteosarcoma. So what grade is a conventional osteosarcoma?
So it is high grade, sir, conventional osteosarcoma.
Right. So high grade osteosarcoma, non-metastatic. How would you like to manage?
So I'll proceed with the neoadjuvant chemotherapy, followed by surgery, followed by adjuvant chemotherapy.
Okay, so the next question would be, what chemotherapeutic agents would you use? How many cycles? And what type of surgery?
So in chemotherapy, sir, methotrexate, adriamycin, in our institutes, methotrexate, adriamycin, and cisplatin is used. And 4 cycles, this is given for 8 weeks, 8 to 9 weeks, sir. 4 cycles of methotrexate and followed by adriamycin, cisplatin. And then 9 to 12 weeks, surgery is done and followed by adjuvant chemo, depending upon the response to the treatment, then whether the same regimen continues, and if the response is poor, then alternative regimen is given, sir. And it is continued till 28 weeks, sir.
Yeah, Dr. Amrit, any question for him that on chemotherapy or neoadjuvant treatment you want to ask?
What is the advantage of neoadjuvant chemotherapy? What are you gaining extra?
Sir, in neoadjuvant, by giving neoadjuvant chemotherapy, it treats a micrometastasis. If there is any, then response assessment is there. Response downstaging of the downsizing of the tumor will be there, and yeah, sir. That's it, sir.
Can we operate the patient upfront and then give chemotherapy? Is this right or wrong?
So in low-grade osteosarcoma, we can, but in conventional high-grade, sir, neoadjuvant chemotherapy is preferred, sir.
So if there's a conventional osteosarcoma, which is huge extraosseous component with pathological fracture and with a fungating necrotic lesion in the skin, would you want to give neoadjuvant chemotherapy, or you can do upfront amputation and then proceed with the adjuvant chemo?
So if it is a fungating fungating mass, then we'll do the surgery first, followed by chemotherapy, sir.
So basically in osteosarcoma, if you do an upfront if you do a upfront surgery followed by adjuvant, there's no difference in overall survival. But the benefits which you've told about neoadjuvant would not be there. So ideally we give neoadjuvant chemotherapy to know the biology of the disease. That is more important than just doing the surgery.
Yes.
So Dr. Himanshu mentioned,
yes.
like Dr. Himanshu mentioned about the biology of disease. How will you assess the biology of disease after giving chemotherapy?
So response assessment is done through the physical examination and through the imaging, sir. That is what imaging was done pre-operatively, that imaging is done post-operatively. And third is, sir, on histopathology.
So you mean to, once you finish neoadjuvant chemotherapy, so basically sir is asking, how do you do response assessment after finishing your neoadjuvant chemotherapy and before operating and after operating? So after operating, you said histopathological assessment. Before operating, how do you assess response?
So before operating, one is physical examination, another is sir, imaging, sir, MRI, sir.
MRI. Do you want to do a PET based response evaluation or an MR based response evaluation?
So if the PET scan is done pre-operatively, then I'd like to do with the PET scan, sir, post chemotherapy also. What imaging is done pre, as there will be available imaging to compare the response, sir. Whatever imaging is done pre-chemo, that imaging I'll repeat, sir, post-chemo also.
Okay, so what surgery you want to do if there is a response to chemotherapy and there are no new lesions in the lung and tumor is remaining same on the MR? So it is still non-metastatic post neoadjuvant.
Yes.
What surgery do you want to do?
So I'd like to proceed with the sir, intercalary resection of the femur, followed by reconstruction, sir.
So you mean to say you want to do a transepiphyseal resection?
Yes, sir. Transepiphyseal.
Okay, and what kind of reconstruction you want to use?
So reconstruction can be done by either autograft or allograft, sir.
Tell us what is routinely done at your institute.
And why do you want to do intercalary? Why not osteoarticular resection? Considering age of the patient, when do you choose either of it? So basically,
So
what
as
you are
the joint
achieving
is
by doing, what you are
as the
achieving by
joint,
doing transepiphyseal resection.
so as the joint is not involved, so I'd not like to do an osteoarticular resection, sir.
Okay. What are the disadvantages of osteoarticular resection?
So as this is a skeletally immature individual, so there will be a if osteoarticular resection is done, then there will be a limb length discrepancy.
Okay. And you would not use a biological method of fixation. You will use a non-biological method of fixation. Even with intercalary resection, there would be some amount of shortening with the patient, which you can manage by doing contralateral epiphyseal depending upon the age of the patient. So that is why, and
Yes.
it is not important to save the limb length. You have to see the margins. If you get a proper margin, then only you should go ahead with intercalary resection.
Yes, Yogesh sir, any
Yes.
questions on reconstruction, sir? Resection and reconstruction, sir?
Yeah, one question to Vivek, we've been answering pretty well till now. You said that you would do an intercalary over here. What are the other methods that can be employed? Or maybe I should ask you, what are the in the intercalary, what are the other reconstruction options that you could use?
So one is this autograft can also be used with a fibula. We can use a fibula for reconstruction, free fibula flap. Then
So basically, you are saying you are using a recycled autograft, or you are using a allograft, or you are using an alone vascularized fibula. Which one do you want to choose? Okay, what all different types of recycled autografts are options are there? What methods to recycle this autograft is there?
So for recycled autograft, we can use ECRT,
Okay.
liquid nitrogen.
Okay. So what is ECRT?
So ECRT is extracorporeal radiotherapy, where we cut the affected part with a margin, send it for the single high dose of radiation, and followed by we use the same for reconstruction. So
How much radiation dose do you give?
So
Okay,
I don't remember exactly 50.
So basically,
single.
you said you would take it out and send it for radiation. So why not
Yes.
just give definitive radiation to this patient of osteosarcoma?
50 grays, correct? You said 50 grays. And what Dr. Himanshu is saying, why not give definitive radiation? Means
You are giving ECRT, you are basically giving radiation only. So why not? Why do you want to operate? Why not just directly give definitive radiation?
send the patient to radiotherapy department directly. Don't send the bone. Is it a good option or bad option, you think?
No, sir. As there is a soft tissue extension which we remove it and then we send a bone for radiation, sir.
Osteosarcomas in general are radio resistant. You can never treat them with radiotherapy. But what happens in ECRT is you give single dose of 50 gray. Single dose of 50 gray destroys everything. And what happens in routine radiotherapy is you give it over a period of 6 weeks, different fractions. That doesn't work in osteosarcomas because they are radio resistant.
Yes.
So
Hey,
what you
Vivek, do you know of any non-biological reconstruction options in intercalary? You have done an intercalary resection. Are you aware of any non-biological reconstruction options?
Sir, prosthesis is used.
Okay. What kind of a prosthesis?
Sir, I'm not aware, sir.
Okay. Any other option apart from a prosthesis?
So any plate cement spacer you can use, Vivek? A plate, cement, nail spacer. Cement spacer. What sir wants to ask? One is mega prosthesis, any implant. Second is, can you use a plate, nail, and cement spacer?
Yes, sir. This can also be used, sir.
So Vivek, you've done the surgery, patient is fine, and post-operatively, what all do you want to check in histopathology?
Sir, on histopathology, I'd like to know the grade of the tumor, histopathological type of the tumor, grade of the tumor, then margin assessment, proximal, distal, and circumferential margin assessment, and sir, response assessment also by looking at the percentage of necrosis. Sir.
Okay, so if it is a poor necrosis tumor, what do you do?
So if it is a poor necrosis, then my adjuvant chemo will be changed, sir.
What do you want to change in the adjuvant chemo?
So adjuvant chemo, as here we give sir methotrexate, erythromycin, cisplatin. So in if there is a patient is a poor responder, then we change it to sir erythromycin, cisplatin, and ifosfamide instead of methotrexate, sir.
I think we have enough evidence to say that changing chemotherapy in a poor responder will not change outcomes. If you ask the examiner this, examiner will ask you to back your answer with some evidence or data. Do you have something to say, support yourself?
No, sir.
So changing chemotherapy in poor responders will not help in survival. Okay, this is something you have to keep in mind.
Yes, sir.
So Dr. Janet, any questions from your side about the management side? Yeah, Janet.
Sorry, I have one question, and this goes back actually to the surgery part. Like one of the common issues that we have with our residents is they are sometimes confused about the timing of surgery. So I just wanted to ask the candidate, when exactly do you do the surgery after chemotherapy? Is there anything that you'd like to see in lab workup before contemplating surgery, or like any time frame after the last chemotherapy before doing the surgery?
So Vivek, he's asking about any blood tests you do and any cardiology tests
Like
you
let's say,
for fitness
let's
purpose.
say you've given 3 cycles of chemo or 4 cycles of chemo, or 2 cycles of chemo, and then you are contemplating surgery. So what are the things that you're looking at before doing the surgery?
So any blood count
So
you
can
do,
you do
CBC or other things, and why you are doing that? CBC, why you are doing after chemotherapy before surgery?
So so chemotherapy causes immunosuppression. So for that we'll do this. And sir, also local imaging will be done, so to see the response assessment after 9 to 10 weeks of chemotherapy, sir. And
Do you do 2D echo for the patient, and why you are doing that?
sir, 2D echo is also done as adriamycin is known to is cardiotoxic. So 2D will see do the cardiac assessment also, sir, post chemo.
And
So I'll
any,
just answer my own question. So it's usually the dip is more towards the end of 2 weeks. So anywhere between 2 weeks to 3 weeks, or you may push it to 4 weeks, but ideally you would want to be within 3 weeks. The patient is usually ready, and one thing you would like to definitely see is whether the ANC absolute neutrophil count is more than 1500, or EM at least 1800. So then when you've got that count, you plan for surgery.
So you get a neutrophil count, absolute neutrophil count. That is important to check it.
Yes.
And if it is low, then what do you do? What medications are given? ANC is low.
If ANC is low, then colony stimulating factors are given, sir. GCSF is given granulocyte. But usually, sir, we wait for 1 or 2 weeks more, sir.
Yes, Yogesh sir, any questions on these aspects, sir, about surgery, chemotherapy, and rehabilitation, sir?
Yeah, no, one question to Vivek. I think we'll have to move on to the next case. Otherwise, we'll be stuck with only one.
Yes, sir, yes, sir.
How would you like to follow up this patient? Everything is done. Your surgery is done. Your adjuvant chemotherapy is done. His treatment is over. Whatever you have prescribed for him. How would you follow him up? What will be the interval, and for how long?
Sir, next follow-up will be after 2 weeks, sir, to see the rehabilitation, how patient is rehabilitating. And from oncological perspective, sir, for the first 2 years, every 3 monthly follow-up is there, followed by 6 monthly follow-up for the third year, and yearly thereafter, sir.
Any investigation you do for these patients on follow-up, or just you clinically examine them? You ask for any workup investigations on their follow-up?
So on follow-up, X-ray of the X-ray of these affected part is done, sir, and yeah, sir, X-ray is done.
Staging workup you want
and,
to do?
Staging, so annually CT scan, CT chest is done, sir.
Annually. So he would come 3 monthly for next 2 years. So every 3 monthly, you would just do an X-ray and annually 1 CT scan. Or do you want to screen the chest more frequently?
At the initial part, you want to screen more, or it is okay with you? 1 year. What NCCN says for follow-up? Yeah, Vivek? For osteosarcoma, any NCCN guidelines may be there?
Yes, sir.
There is a guideline from Tata Memorial Hospital also about these workups, that how to follow these patients. TOS trial was there. Trial on optimal survival is there. So published by Puri sir and the group. So that is available. And what NCCN says for these tumors, how you follow them and what workup you do. MRI, there is any role of MRI on follow-up, or it is not required? The medical oncology guys ask for MRI on follow-up regularly. So is it written in NCCN or?
Sir, I don't remember exactly.
No problem. So you answered the questions very well. Yogesh sir, any other questions, sir, about this case, sir? So
No,
we can
I think he did reasonably well.
Yes,
we can move on to the next case.
yes, sir, definitely, sir.
Abhijit, I'll have to wrap up by around 7 o'clock. So
Yes,
I'll
we'll finish, sir, by 7 o'clock, sir.
Oh,
We'll just do that case fast.
Yeah, okay. All right. So most of the workup aspects we have covered in this case.
Sir,
So
yes, sir.
next
Again,
case.
I'll also show the video, small video, and then.
Okay.
Yes, sir.
Sir, if the student can present the examination findings,
yes,
that
sir,
would probably help him, and then maybe you can show the video.
Okay, sir. Okay, so this is the case. So I am not shown in this case.
Oh, okay.
So he doesn't know the case. Oh.
Okay, then we go ahead with the video.
So can we see this? Yes, is this visible?
Yes, sir.
Yes. So again, same pattern. It's a 14 years boy with pain and swelling on the shoulder, short duration history. And this is the inspection. You can see inspection, palpation, and all the findings. Yes, Vivek, you can summarize your case on the clinical and imaging findings. So,
Sir, this is a 14-year-old boy who presented with a pain and swelling over the left shoulder for the past 2 months and associated with a wrist for the past 2 months, and with a uh,
so you can tell about the origin. You can tell the.
yes, sir.
You need to tell the anatomical diagnosis, which area is affected. You need to tell the pathological diagnosis, how what it looks, infection or tumor, or whatever thing you think it is. So
Yes.
anatomical diagnosis, you think the tumor is arising from scapula or humerus, you think?
So this tumor could be of as it is seen, so this is arising from the scapula, sir.
So that is anatomical diagnosis. Then the pathological,
And
what do you
it
think?
is
It's
most
neoplastic or
it is most likely to be malignant, as the diagnosis is mentioned already, osteosarcoma of the left scapula, sir.
Yogesh sir, your questions for this case, sir?
Yeah, I think I wouldn't spend a lot of time on the workup part
Yes,
now.
sir. Yes, sir.
We consider him to be non-metastatic for the sake of discussion right now.
Yes, sir.
Okay, so Abhijit had already marked out the incision, final incision as well. Supposedly he has responded moderately well to the neoadjuvant chemotherapy. What would you like to do for him, Vivek?
So your surgical and Vivek.
So I'd like to proceed with the resection of the scapula, followed by a reconstruction with the customized scapula, sir.
Abhijit, do we have a post-chemotherapy MRI?
No, sir. This was the thing what I had prepared for this case, sir. Clinical findings only, sir, were made for this.
Okay, right.
So we assume, sir, it is responded well, Vivek, what sir has said. And you want to resect the scapula. So how you reconstruct? What are the methods of reconstruction here? You said customized scapula. What is
Sir,
meaning of that, Vivek?
sir, customized scapula in which so the scapula is measurement is taken from the opposite side of the patient, and similar to that, using a titanium material, scapula is reconstructed, sir.
That is one option. Any other options you know? So we are not having that facility if it's not available.
Vivek,
Then any
what,
other
what
option?
makes you to decide whether you want to reconstruct a scapula or not? And why do you want to reconstruct?
So as patient has achieved a good response, so if this is scapula for the limb movement and all, so scapula is required. And
So basically, sir's question is, what are the important structures that will lead to limb movement? Now tell us, what are the important structures for the shoulder movement here that are around the scapula?
so one, so the this so muscles and so this deltoid muscle and supraspinatus and
So basically the rotator cuff, which you are telling, and you are telling about the deltoid muscles for abduction. For
yes, sir.
rotation, the rotator cuffs, and abduction is the deltoid. For flexion, you'll have the deltoid and the biceps. But the question is, when you remove the scapula, will you not cut all these muscles? Because they all originate from the scapula. Will you be able to save axillary nerve? If you're cutting the rotators and you're not saving the axillary nerve, how would a reconstruction of scapula help? See, the MR which you see, there is a huge extraosseous component. It would be very
Yes,
difficult to save the axillary nerve and you are cutting all the rotators. So even if you reconstruct scapula, what for shoulder function he might have? So it is easy to customize, but to give results after customization depends upon what kind of resection you are doing. So if you are getting good range of function, then you customize. Otherwise, I don't think so. You need to reconstruct the whole scapula, put a metal scapula there or an artificial scapula. You can just tie the shoulder around the clavicle with a Mercilin tape or a Thibond sutures, and at least he'll have good range of elbow function.
So Vivek, do you know any classification of tumors around the shoulder? Any surgeon's name is there? Classification? Very commonly asked in MCQ exam. What is the classification of the tumors around shoulder joint? Any name of the classification? A famous author's book is there.
Malabar.
So Malabar's classification is there. Very common question in MCH exam, theory and practical. So there are very few classifications of tumors, fibula or pelvis or scapula. So you should know what is Malabar's classification. So that will be important for you in exams.
Yes.
Yes, Yogesh sir, any question about this case, sir?
Yeah, suppose patient cannot afford a scapular prosthesis. What would you do, Vivek?
Sir, as sir said, just tie the head of humerus with the clavicle with the Mercilin tape and or
So have you
Ethivon
heard
sutures,
the
sir.
term Tikoff-Lindbergh surgery? Have you heard this term, Tikoff-Lindbergh surgery? No.
Yes, sir.
So what is that Tikoff-Lindbergh?
So it is a 4/4.
No, not 4/4. So any biological methods you can use here, as in you are described in previous case, any biological methods. So customized 3D implant is very costly. So can you use any biological method? You can radiate this bone or liquid nitrogenate. So that can be done, or it's not possible for scapula. So So can we do ECRT or liquid nitrogen for scapula?
Sir, I am not aware, sir.
That's okay. That's okay. What you
Yes.
need to know is the different options. And as Dr. Himanshu mentioned, scapulectomy and only the resection, and then just fry the muscles is the most commonly done. Whether you need customized processes or all these other ones are the options that you need to know, and probably if the examiner goes into those details.
So there is a
Yes.
third short case, sir. We can finish in 5 minutes, sir.
Okay.
So that is a short case, benign case. So it completes the things. So we have last case for you. Before your
Yes.
final exam, you are totally grilled properly. Yeah. So a young girl of around 8 to 9 years, and this was her inspectory finding. So there is something on the left forearm region. Left forearm is smaller and shorter as compared to the opposite side. This was the elbow movement, wrist movement. So this was our flexion and extension. Finger movement was good. The parents complained of small left forearm area. So that was the only complaint by the parents. Otherwise, she was functionally okay. The forearm looked smaller to them, and they thought that there is some. This was the opposite side X-ray for you. Normal side X-ray, and this is the disease side X-ray. Yes, Vivek. What do you think here? So you have very small time. So 2-3 minutes time is there. You can tell what findings are here, and again a very common case asked in orthopedic exams. A
So
young
this is
girl,
a case of
a young
eccentric.
girl with shortening of the forearm, and her parents thought it's a smaller forearm, and they thought there is some swelling around the elbow region also. These were the two complaints. So some swelling around elbow region and shortened forearm. These two complaints. Otherwise, the kid was doing all the activities. Yes, Vivek.
Sir.
What do you think here it is?
So this is eccentric expansile lytic lesion over this ulna.
Yes. And anything happening to the radius?
And for
Normal
which is
position or it is
causing the
dislocated?
which is causing the bowing of the radius, sir.
Yes. And do you think it is normal in position or dislocated here? Radial head, upper part near the elbow.
Yes, sir. A radial head is dislocated, sir.
Yes, Yogesh sir. Your quick questions about this case, sir, so that we can wrap in 2 minutes, sir.
Yeah, Vivek, how do you want to manage? Any further investigation you would like to get done? Any radiological investigation? Anything else that you want to do? And how will you manage this case?
Sir, this is bit difficult for Vivek, sir. We
Okay.
generally refer this to pediatric ortho people, sir.
Yeah. So Abhijit, why don't you wrap it up?
So Vivek, what do you think? It looks to be of a case of a benign tumor.
Yes, it
So
is a
you
case
need to
of
look the classification. It's more in an orthopedics case. So you need to know the classification of what is happening around the forearm. So Masada's classification is there. And what things should be done for this case that needs to be planned. So you need to tackle the forearm length. You need to tackle the radial head. And that thing should be planned for this patient. Yes, any other comments
Yes,
from
sir.
all other examiners from our side?
Hi, sir.
How Vivek
just a
can
comment
improve?
that-
So how
Yeah,
Vivek
yeah.
can improve in his exam, final exam, which is after 3 months. So
So Vivek,
suggestions
did
from
a good
Vivek.
job presenting. Just for this particular case, probably what to expect is that it will be a swelling in the forearm. They'll be asked to examine the forearm and describe, go in the usual pattern, inspection, palpation. If this comes as an exam case, probably that is what is to be stressed upon the examination findings. The management would be the later half, and probably, as you mentioned, it is more of a pediatric ortho case. But other than that, we did well in the initial case.
So final comments from all our examiners, Srinath, Himanshu, Dr. Janit.
I think you did well.
Yeah, please go ahead.
Hey, Dr. Himanshu, you first.
I think he did very well, but it's just one thing which I would want him to do is not to just give the diagnosis like Dr. Yogesh said, like osteosarcoma in history or something like Ewing's. Just say it is a neoplastic etiology, probably malignant, which I'll confirm with my radiological investigation at the history level. Going up to the diagnosis is the only thing which would make sure that you'll pass. But if you tell the diagnosis beforehand, then the examiners, they feel that you've already know the case or something like that. So keep it very simple. I don't think so it would be difficult. You already know most of the things.
Yes, sir.
And one more point I would like to add is stick to what is done in your institute, because what is followed in an institute like that will be all evidence-based, right? So if an examiner asks, you can point it out saying, this is usually done in our institute. And then if you can back it up with evidence, then nothing better than that.
Yeah, Dr. Janit, any final comments from you, sir?
I think Dr. Janit has left. Dr. Amrit is there.
Okay, sir.
And
Dr. Amrit, any comments from your side?
I think Dr. Vivek has done quite well for the range of questions asked at him.
Yes, sir. Yogesh, sir, your final comments, sir, and Pratik's comments, sir. So we can summarize this year of this session.
Everyone has put it. Vivek did reasonably well, and he's given us a fair bit of an idea about what his understanding is. So I think he would be able to pass if these are his cases in the exam.
So this will be a short case, sir.
Yeah, well done. I know that. Well done, Vivek, and all the best to you. And Pratik, is Dr. Gulia joining us?
I think he has already joined, sir.
Yes, sir. Gulia, sir, your final comments, sir.
Yeah.
Heartiest congratulations, Vivek. You presented well, and I think the last case was a bit complex. It's just not osteochondroma, but it's radial club hand, where you have shortening of the radius with dislocation. So I think you've done well. I completely agree with the comments from Dr. Panchwaz, Dr. Srinath, and other people that you just need to keep things simple. Don't get worried. Stick to your findings. Whatever you are seeing, you just need to say it in a scientific manner, in a clinical manner. I think that's what is more important. Diagnosis is not the important. Doing the examination properly is what is very important. So I think congratulations to you. And for the last session, thank you so much, everyone. From the bottom of my heart, I want to thank all the faculty, all the delegates who have joined us in all 12 sessions. This was a very different experience for us. And this was a very unique program, which I had thought about 8.5 years back, where we wanted to cover all the basics of musculoskeletal oncology in 12 sessions. Though I would have liked that the presence of delegates would have been a bit higher, but I think it is okay. We'll keep continuing our efforts in this way, and we'll keep continuing this program of nurture the future in orthopedic oncology in the years to come as well. And lastly, a sincere thanks to Dr. Pratik Hegde, who has been the backbone of this entire program. It's basically my thoughts, but his execution, which has made all the difference. He's been there as a rock solid pillar for this program, and I want to congratulate Pratik. This is your show. as I discussed that in the years to come, we're going to make it more bigger and bigger. Now we have IOA affiliation, BOS affiliation, IMSOS affiliation, all three affiliations with us. In the coming year, we will get it affiliated by other state orthopedic bodies as well. We will ensure that each session we will have some international speakers or the faculties participating as well. So again, you know, a big round of applause from my side to you for this Herculean effort which you have put. And I assure you that from Sarcoma Education Foundation side, we will have all the support going for this program in the years to come. And we will ensure that all these recordings will be edited and will be there on Sarcoma Education website as a free resource for all the students, whoever wants to get benefited with this. Once again, thanks to all the faculty, thanks to all the delegates from all the sessions, and being inspiration and support for this program. Thank you so much.
Thank you, sir.
Thank
you,
Sir,
Ashish.
what is
Thank
your
Thank you,
final
sir.
comments?
Thank you for the kind words, sir. And I think everyone did a good job. Thank you. Thanks a lot. Thanks a lot, Yogesh sir, for taking time out. from
Thank
your
you.
schedule. Thanks a lot, Ashish sir, for joining us and encouraging us. Thank you, Abhijit sir.
I just landed. I saw your text. I just landed. Thank you so much. Thank you so much.
Thank you. Thank you, Dr.
Thank you.
Abhijit, for arranging
Thank you,
this.
sir.
And thank you all
Thank
the
you, sir.
panelists and the delegates. It was a good session, and hopefully we'll be back and do something better. Thank you all.
Thank you, sir.
Thank you.
Yeah.
Bye, sir. Thank you, sir.
Thank you.
Thank you.
Yes, Vivek. Bye.
Thank you, sir.
Thanks.
Thank you to Somnath ji and Hemant ji for being the backend team and for conducting the quiz also.
Thank you, Dr. Pratik sir. Thank you, Dr. Abhijit.
Yeah, thank you, thank you. Hopefully कुछ और plan करेंगे and फिर आगे देखते हैं.
Ji sir, definitely sir. We'll be there.
Thanks a lot. Thank
Thank
you.
you.
Well, take care.